20.
The views, opinions, and advice in this podcast are not necessarily those of our employers. Medical topics are discussed largely using best EMS protocols. Discussions here should not replace your own services, policies, and procedures. Hey guys, today we're going to be discussing some issues that Dr. Northeim and Dr. Bertrand have seen as common issues among EMS from the perspective of medical direction. We're going to be going over pneumothorax, spinal mobilization, and sedation/pain management.
All right, so next we're going to kind of talk about today is tension pneumothorax, and we will routinely see patients come in the emergency department who have a needle decompression performed. I think it's important for us to understand why we're doing a needle decompression. It's not for a pneumothorax, it's for a tension pneumothorax. And so although JVD and tracheal deviation are things we're probably not going to see very well in the field, sometimes lung sounds are even really hard to hear, especially on the highway, maybe a bad wreck. Someone's getting extricated, back of an ambulance, obviously very loud with generators and air conditioners going, especially when it's 105 out. I think the important part is that these patients that are getting darts should be unstable, right? They should not be the 2-liter nasal cannula satting 98% with a completely normal blood pressure. They should be getting darts if they are hypoxic or having a hard time maintaining sats on a non-rebreather, or having a hard time bagging them, or getting hypotensive, or getting tachycardic. I think that's kind of the moral story. And if you perform a dart on someone who doesn't need it, you could essentially, especially with positive pressure, you could essentially give them a pneumothorax. And I think it's important to know that majority of your trauma patients do have a small pneumothorax by the time they come to the emergency department. Most of those, unless they're vented or unless they have positive pressure, we're just kind of watching them, right? And so I think the moral of the story is, please hold off on darting someone unless you're going down the tension pneumo, right? Pressure's good if heart rate's good. Sats are easy to maintain on some low flow supplemental oxygen. Probably not take that step. Certainly monitor. Certainly keep that in your dope algorithm when you have an intubated patient, because the pneumos can become tension pneumos quickly. But we do see that a lot. We are moving to primary location, 4th and 5th lateral instead of anterior. I think some of the newer studies are showing a little bit higher rates of success. We use a 14 or a 10 gauge 3 1/4, depending on agencies within Best EMS and PCHD. And we actually have moved to finger thoracostomy in our trauma rest. So we've done quite a few here. And I guess the beauty of a finger thoracostomy on a trauma rest is you're in a good position, and it's not going to re-occlude. We did have one patient here that we did with a pulse, and that's because we ran out of needle decompression needles and kept needle decompressing the patient, kept reaccumulating, very sick patient, did finger thoracostomies, and the patient had a great outcome. But I think we see that quite a bit too, where someone gets a dart and maybe doesn't need it, or we kind of ask them, hey, what was their blood pressure, what were their sats, and they're pretty normal. So I would just say another example of, kind of do no harm, wait to see how the patient declares, and certainly if you're worried about a tension, absolutely do the procedure.
Yeah, certainly if you are, like you said, seeing signs of hypotension, you don't hear any breath sounds. I think I get a lot of patients who got a dart, and the question was, well, I think their breath sounds were a little bit diminished. It's really hard to assess really good breath sounds in the field, right? It's hard to assess in a busy emergency department. So, just look for those signs of tension pneumothorax and really make sure they're there before you commit somebody to a dart, because more than likely, even if they didn't have a tension pneumo, you're now committed them to receiving a small chest, a minimum a chest tube, hopefully a small one, but most of the time you're committing them to get that.
We had a fairly bad trauma a few months ago, and I was on the fence with darting this person. They seemed fairly stable. They were like maybe mildly hypoxic. We'd had to RSI for a traumatic brain injury type symptoms, and I ended up darting. I'm not sure. I don't think the follow-up ever confirmed whether or not it was justified or not. But the sign for me that pushed me over the edge was we stopped being able to get a blood pressure. Like it was like, okay, because I knew there was diminished lung sounds or absent lung sounds on that side. Yeah. But then it's like, okay, that blood pressure didn't come back. I can't feel a radial pulse.
Oh, yeah.
Or-
Absolutely.
Like, it was like,
Definitely needed.
and whether or not maybe I just couldn't feel radial pulse at that time, but it was the blood pressure change that I was like, okay, I'm just going to do it. And if I made a mistake, then it is what it is. But the blood pressure change for me was like, I'm doing it. Yeah.
And in that case, it's a life-saving maneuver.
Absolutely, and I think the important thing on anything we're doing laterally, whether it's a finger thoracostomy or we're doing a needle decompression, is, if you're scared of where you're at level-wise, it really should be anatomic nipple position, anterior axillary line. But you can also take, your fingers like this and kind of shove it up in the armpit, and that should really give you about the fourth. But if you're worried about it, always err towards the head. We see a lot of these patients who obviously are not breathing, their diaphragm is high, and in cadaver lab, some of these needles that some of the students are doing, once we open the chest, we're like, whoa, that's below the diaphragm, right? And so the ultimate point is we got to get into, the thoracic cavity. We have to get in there to relieve the tension. But if you're going to err, right, adrenaline's pumping, is always just go up a level and it should be safer.
Next topic we wanted to discuss was immobilization, specifically cervical spine immobilization. Over the years, everyone knows that we've gotten more relaxed with not committing patients, certainly to backboards and that uncomfortableness for hours on end. And also with regards to C-spine, right? We give crews a lot more leeway in determining who needs cervical immobilization. But sometimes it seems like we've swung the pendulum to where it's getting unsafe. So we've had several patients come in recently that are these little elderly patients that have a history of dementia, that are maybe at a nursing home, they've had a fall, it's most of the time an unwitnessed fall, they have a laceration to their forehead, and they're coming in with no cervical immobilization. And there's no way you can clear that patient clinically because of their altered mental status at a baseline, and most of the time we don't know how altered these patients are at their baseline, so now we could have someone who's even more altered than their normal demented state. So we just want to stress that if you cannot clear them clinically, if they have any altered mental status, any level of intoxication, certainly a large obstructing injury like a femur fracture, any kind of long bone fracture, severe abdominal tenderness, all of those patients should be immobilized with the cervical spine immobilizer prior to transport. The other case I see sometimes is it's a question of whether it's a traumatic event, but it's a question of whether there was a medical event that preceded it. And I've had a couple come in where, it was described as, well, people were driving, we saw this person pass out while they were driving and they wrecked their car, and they're altered because of their initial medical event or possibly trauma event. And I've had a couple come in with no cervical mobilization and they have an altered mental status, and the crew says, well, it was definitely a medical event. And I'm like, well, they still had a traumatic event. They still, hit a guardrail. They still rolled their car. And actually I had one that had a cervical spine injury in a case like that.
It doesn't matter why they're altered. They're just not able to communicate. They're not able to actually self-assess, right?
Yeah, I think the most common one is, like he said, the demented patient. Like, well, they're always confused. Well, you still can't clear them. And I think back in the day, right, when we used to do EMS, no matter if we collared somebody, we had to board them, right? And the beauty for you guys now is just because you collar them doesn't mean you have to board them, right? And so we would, back in the day, kind of talk ourselves out of collaring someone because then we had to board them. The beauty is, if you have any question at all, just throw the collar. And how many times do you palpate the neck and everything's fine, and you get to the ER and they're like, oh, he's midline neck pain. Like, oh, great, right? Yeah. Just like us. You could go see a patient, I can go see a patient, and we're probably going to get 3 different stories, even though it's only 2 of us, right? And things are going to change. So I think that's an important piece. I also want to stress that if you put this on the demented, frail person, and you deliver them the ER and the collar is to their nose, that's probably not doing much good, right? And so we see that a lot. Or if the patient's actively fighting with the collar and moving their neck, that would probably be something good to put in your narrative of, hey, patient didn't tolerate collar, was actually fighting the collar. I'd rather have somebody kind of sitting there not doing a whole lot than trying to fight a collar, because that's obviously making things worse too. So I think there's obviously some documentation, I think there's some common sense, but we just thought that was a good clinical pearl because we happen to see that a lot.
So, devil's advocate real quick. So you're talking about dementia, and that's a very progressive disease. There's a broad spectrum of dementia patients. Is there a dementia patient that has fallen on the ground that I can C-spine clear? Does that exist? somebody that maybe is just kind of early on, maybe they just don't know where they're at. Like where's the line is I guess what I'm asking, because if somebody I've met a lot of people who have a diagnosis of dementia, and they're talking to me like I'm talking to you. And maybe when you delve into it, okay, now they don't know who the president of the United States is, but everything else they are totally aware of, they're totally with it.
I would say play it safe with that patient and let us have to make that decision.
Okay.
Put that on us. And I kind of consider the same thing with pediatrics, right? I see a lot of pediatric patients come in that I think should have a C-collar that don't. And it is pretty rare for a pediatric patient to have a cervical spine injury. They're just so limber and everything, but they can. And so, when I see it and I think it's needed, I tell the crews, hey, just go ahead and play it safe and put that decision on me. I'll be the one who has to make that decision if they really need to stay in the C-collar, if they need a scan or not. So it's better to play it safe, I think, in these patients and have us make that decision than to have someone moved around and transported with an unknown cervical spine injury. What's your opinion?
I agree. I would play it safe. And I think the other big thing, especially in Texas, is language barrier, right? I mean, you could have somebody that's alert and oriented that you just can't get a good history. You're not really figuring out what exactly happened. You're having a hard time communicating with the patient. I mean, I think it's safer on those patients as well, and I'd probably place a collar. We have a lot of agencies doing a really great job with, collaring somebody using a scoop stretcher, getting them to the cot and taking the scoop stretcher off. I would say make sure you take the scoop stretcher off, right? The point of a scoop stretcher is you scoop the patient, you put them on the cot, and you take it off. And I had one the other day that, this guy literally had isolated neck pain, but he had a hard time getting up because his leg hurt, got him over to the cot and kept him on the scoop stretcher, basically one of the hard board ones like we have, right, for 20 minutes. Well, by the time we got that off, guess what he had? He had a posterior headache, he had T-spine pain and L-spine pain, right? So now he's probably getting scans of 4 items versus just his neck, right? And so we love, scoop, take the scoop off. I think vacuum mattresses are great. I think they're really great for the elderly with hip fractures. Make sure if you're using a vacuum mattress that you're putting a sheet down first. And really that vacuum mattress shouldn't leave your cot. Ultimately, we can hold C-spine, we can use a sheet, move the patient over, but it's really hard to get them off the mattresses once they come to our stretcher, right?
Oh, yeah.
I mean, it's hard to roll them because they kind of have those little wings that come off once we roll it. And so I would say always keep the mattress on your cot, always pre-pack it with a sheet, move them over with the sheet. But, a multi-system trauma patient that we're loading and going, I would board and collar 100% of the time. I wouldn't mess around with a mattress. I just think it takes longer. Then you got to blow it up and all straps. I think, load and go situation, we are still fine with board and collar. They're going to get scanned. They're probably going to get pain meds, right? They're going to get pain scanned for the most part. Yeah. So we're just talking about the one that we're worried about a neck, right? We can't clear them. Just another clinical pearl.
So, and this is kind of not quite off topic, but we just got droperidol fairly recently. Would you ever consider, that dementia patient who is pulling everything off, is kind of fighting you, but you're like, man, this person needs a C-collar. Would you ever consider 5 milligrams of droperidol to calm them down and keep that C-collar on?
I would say if you have enough clinical suspicion that they need the collar, I think that's a good call.
Okay,
yeah.
Cool.
Yeah.
That's a new drug for me. I have yet to give it. I'm excited to give it. So, this next topic, we're going to talk about resedation. We like to resedate every single patient that we're intubating, and we usually do it pretty much immediately after actually getting the tube, getting it secured. First of all, I'm going to talk about reparalyzing. So I've seen a lot of people reparalyze. I've seen different agencies reparalyze. It seems like it's more commonly a small hospital that is reparalyzing because their patients are difficult to deal with, and the 10 mics of propofol isn't cutting it. I'm not a fan of reparalyzing. I never have been. I've only done it on a handful of patients. It makes it way more difficult to assess your patient's level of pain. It makes it way more difficult to assess your patient's level of discomfort. If somebody's not paralyzed, then you're able to actually see, okay, they're moving, they're starting to choke on the tube, they're starting to open their eyes, stuff like that. If your patient is paralyzed, you have to watch for heart rate. You have to watch for, that's pretty much it. Like maybe
hopefully not tears.
Yeah, tears. Yeah. Tears would be the only other real thing that you could watch for, right? So we're watching for heart rate. Well, how many of our patients are elderly patients that are on a beta blocker? Yeah. Like, you may not always see tachycardia. So you may be thinking like, hey, this 50 of ketamine that I'm pushing every 10 minutes is doing a great job. Sometimes people don't respond to ketamine at all. Like, how many times have you given a dose of ketamine that you think would be appropriate, and then they're still awake and like, hey, what's going on? So the last thing we want to do is basically create a living nightmare for somebody that they're completely aware and we just don't know it. The process of being intubated, the process of being ventilated is extremely uncomfortable. And so we use ketamine, we use Versed. Obviously, we can use fentanyl in conjunction with that. We use ketamine drips, and I'm a huge fan of a ketamine drip because you're not going to forget to push it again at 10 minutes, and you can titrate it really easily. We can go all the way up to 3 milligrams per kilogram per hour, and I've found the sweet spot for me, 2 milligrams per kilogram per hour seems to get pretty much everybody where they need to be.
No, we have several options. I mean, we have Versed drips too. We have propofol. So really, depending on what our vitals look like, we have lots of options. But I'm not sure how often skipper long-term paralyzes, but I would say less than 5% of my cases that I intubate do I end up coming back and doing long-term paralytics. Sometimes in a trauma case or stroke where we have to, really keep them from moving in CT. Maybe we would do it in that case, but we're still actively sedating, resedating, adding some narcotics to it. Yeah. I just feel like there's a lot of services that feel like because the long term, if you don't use it initially, right? So PCHD, we use ROC initially, but if you're an agency that used SUCS initially, I feel like there's a lot of agencies that feel like they have to go with ROC because it's in the bottom drawer of that Craftsman toolbox. I don't think we have to. I think we have to do a better job sedating. I think adding narcotics to our sedation medication is really important, but I agree. I mean, rarely do I, only if we're kind of getting to the point where, man, we got to get this person to CT, we got to figure out what's going on, but not replacing sedation. And I think there's some transfers that we have taken from different facilities where we get there and we say, hey, what did this patient have? And they initially got maybe etomidate or ketamine and they got ROC and they haven't had a single other drug for sedation, right? And so I think this is really important on the hospital side too, especially maybe some of the rural facilities to really make sure we're educating on, right? But we've got to resedate. As soon as you get the tube, tied down and make sure it's good in your capnography, you got to resedate. And we're actually moving to not even a timing on our resedation, right? Because, I mean, what's worse than sitting there and say, I got another 6 minutes before I can resedate this person, and the patient's moving. And that's not what we do in the ER. We don't time it every 5 to 10 minutes, right? We'll get them on a drip, and if they need something, we're going to hit them with a benzo. We're going to hit them with some ketamine or whatever we need to do. And so we're kind of bringing, some of that ED experience out into the field and making it easier on the crews. If they have a tube in place, as long as their blood pressure's appropriate, let's continue with resedate with the medicine that makes sense.
And especially with propofol, getting started on the drip, it's kind of hard to find that magic point where they're really sedate. So don't be afraid to go ahead and give them another bolus of propofol. And, I do that all the time. I'll get a question, hey, they're on propofol, but they're still moving around. Well, just rebolus them. As long as their blood pressure is good and they're not hypotensive, then we're not going to hurt them. Let's just take care of them and resedate them.
Maybe add some fentanyl in there.
Yeah.
That's one thing that I've seen quite a bit is whether it be the hospital or whether it may be a unstable patient in the field, their blood pressure is not good enough. I can't give them more sedation. Well, the nice thing is ketamine typically doesn't cause hypotension, but also you need to sedate that person. So sometimes just a little fluid resuscitation, maybe a low dose levofed drip, something to get them to the point where you can actually take care of their sedation the way it needs to be.
I actually heard one of our supervisors here yesterday talk that, a busy call, you kind of lose track of time, right? 8 minutes is like that. Yeah. And so what she normally does is she will set her phone or her Apple Watch for 5 minutes or 8 minutes, whatever you want to do, right? Great. And so even though, she may have forgotten it, her alarm's going to go off 8 minutes. Okay, probably time to reconsider some sedation. Depending on what drug you're using, set your clock different. But then she'll hit reset, and in another 8 to 10 minutes, right, or 5 minutes, it will remind her again.
So one other thing to talk about with resedation, just kind of getting back on track before we move on to the last two topics. You can always use a combination of medications. And I think that people kind of get one-track minded sometimes. Hey, I gave ketamine. Hey, it didn't seem like it worked. I'm going to give more this time. Okay, it didn't really seem like it worked. I'm going to give more this time. switch gears. Sometimes just it doesn't work. Sometimes you're going to need to give some Versed on top of it. Sometimes a little fentanyl to get their pain under control, and then lights out. So
narcotics work terrifically. I mean, I think there's some studies that show narcotics first actually work really well. I would say whatever medication you carry, really, use the medication that makes the most sense for your vitals, right? So if you have a patient that's super hypertensive, you're worried they have a head bleed, probably a good idea to go the Versed fentanyl route for us, right, or propofol route. Somebody that you're trying to get the pressure up, hopefully have enough sympathetic surge left that the ketamine will work. But absolutely, I mean, mix things up. I think we do that all the time.
Would you ever, and again, this is droperidol new for me, would you ever consider adding droperidol in to that, or is it just not in that class?
Yeah, I think it's a better, the way we look, I think, at droperidol, especially in the 5 to 10 doses, it's a really good antipsychotic for someone that's delirious, actively psychotic but not violent, right? And so I don't think it's a really great, I don't think anyone's using it for event sedation, at least we're not. I don't think the ICU folks are either.
I don't think it's strong enough.
Well, obviously it would be in combination with a stronger drug.
Yeah.
Okay.
I don't know how well it's been studied. I haven't heard anything, but certainly something to look up. I think we have enough meds in our arsenal.
Yeah. And certainly the other thing I want to say is just even if we're not talking about an intubated sedate patient that we need to keep sedated, but on pain control, I get calls frequently that, we've given patient 3 doses of fentanyl and they're still in a lot of pain. Can we give a 4th dose? Mm-hmm. And often I tell them, well, why don't we try something else? Yeah. Try your other pain modalities that you have to use, because obviously it doesn't appear that they're working well with whatever you're trying. So let's just try something else first before we give another dose of the same medication.
Right. Yeah, there's a lot of good studies now on multimodal pain, right? So, the most recent study showed if you do, 2 Motrin/ibuprofen with 2 extra strength Tylenol, so 400 milligrams of Motrin with 1,000 milligrams of Tylenol together with a snack every 6 hours, something in your stomach, you actually have, in blinded studies, those patients actually have less pain and less side effects than the narcotic subgroup, right? Wow. Cancer pain's a different deal, probably an open femur fracture, but I think it's important that, we carry IV Tylenol now, and IV Tylenol may bring your pain score down 2 or 3, right? But adding that to potentially the morphine or the fentanyl and trying to create a multimodal pain distribution during transport, I think's good, and I think the patient will have better pain relief if you kind of use multi.
Yeah, definitely.
Cool. Would you ever use Tylenol and fentanyl at the same time?
Sure. I mean, I routinely, kidney stones and stuff, I'll give them a gram of Tylenol, I'll hit them with Toradol, and then I'll hit them with either fentanyl or morphine. I think, and the one really important piece is make sure if you're carrying morphine that you're actually doing the weight-based dose for morphine is actually 0.1 mg per kg. We routinely give 4 morphine. Well, 4 morphine for, the 100 kilo person is not going to be enough. We routinely give fentanyl at pretty good doses, right? If it's 100 kilos, we're typically giving 100. Some little old person, we're probably giving 50 or 75. I feel with morphine, we automatically stick to 4. We rarely hear 8, right? And so I would say if you have a bigger person that has good kidney function, go with the higher dose. We used to routinely give, I remember EMS would come in, they'd give 2 milligrams of Dilaudid over a 15-minute transport time, and that's 14 milligram equivalents of morphine, right? But yet, when we go down the morphine route, we're given 4, right? So I would say that's some good education as well for the crews.
0.1, got it. And push it slow, right?
Push your morphine slow. If you push it slow, it actually shows that it doesn't cause nausea to the patient that doesn't start nauseous, right? You got to push it slow. Same thing with Reglan if you're carrying that. Reglan has to be pushed slow. And so when they did, slow push versus fast push, there was a considerable difference in the side effect profile for Reglan. And so we'll hear in the ER, she wanted to run out of the ER from Reglan. Well, I gave it over 20 seconds. Well, it's too fast. Yeah. So give your Reglan slow, even like your Phenergans. I mean, any of those, droperidol, give it slow. Narcotics, give it slow. But you could take a patient who has 0 nausea and give them morphine slow and actually do quite well. And you don't have to waste Zofran and draw it up every time, right? So.
Well, guys, I'm going to cut this one off there. We had a few more topics we went over on that day, but I'm going to put it on a different podcast in order to try and keep these closer to 20 minutes. Thank you guys for listening. This has been an episode of the PCHD EMS Podcast. Thank you for joining us.